Welcome to Overcoming Physician Burnout as Health Architects, a series in which we talk about different ways that physicians can approach their clinical work to make it more rewarding and fulfilling. This is Venkatesh Ramnath. Today is episode 19, a conversation with leading communication experts on restoring agency and trust. In the written post, you'll find links to references cited, as well as a QR code that you can click on for more information about my guests on the podcast today and the Center for Compassionate Communication at the Sanford Institute for Empathy and Compassion at UC San Diego, where they work. Dr. Evonne Kaplan-Liss is the director of the Center for Compassionate Communication at UC San Diego's Sanford Institute for Empathy and Compassion, where she leads an interdisciplinary team of artists and medical professionals to teach compassionate communication. She began her career in journalism after graduating from Northwestern University's Medill School of Journalism and landing her first position as a researcher for Ted Koppel on ABC's Nightline. She then left journalism to pursue her lifelong dream of becoming a physician, earning her medical degree from the Icahn School of Medicine at Mount Sinai in New York City and her master's degree in public health from Columbia University, before she completed residencies in preventive medicine and pediatrics. Before joining UC San Diego, she held the first dean-level position focused solely on training healthcare professionals to communicate with compassion and clarity at the Ann Burnett Marion School of Medicine at Texas Christian University in Fort Worth, Texas. In 2009, Dr. Kaplan-Liss was the founding medical director of the Alan Alda Center for Communicating Science at Stony Brook University in New York, where she trained thousands of clinicians and medical students in empathic communication. Val Lantz-Gefroh is a nationally recognized expert in using the arts to transform communication in healthcare. As a director of communication education at the Center for Compassionate Communication at UC San Diego and a founding faculty member at the Alan Alda Center for Communicating Science, she has trained countless clinicians and researchers to connect with empathy and authenticity. With a background in professional theater, she designs and leads workshops that draw on improvisation, narrative, and performance to build trust and presence in medical settings. Val's work bridges the worlds of storytelling and science to foster more humane, effective communication in healthcare. Welcome to you both.
Thanks. Nice to be here.
Thanks for having us.
Great. Thank you for taking the time. I wanted to kind of start with Evonne. You have a journey that began in journalism, and then you moved to medicine and public health. So maybe can you share a little bit about your story and how you came to have the path that you have and how that led you to this world of empathic communication?
Sure. My story really starts even before my journalism career. At the age of 15, I was diagnosed with ulcerative colitis and had a very rapid and severe course, meaning I was hospitalized and had 21 surgeries over the past 3 decades. And I realized during that journey, along with my family, that really at the core of my care and what was most important to us as patients was communication. And I was on the receiving end of great communication, but also not so great communication. And I had always wanted to be a doctor, but my illness kind of took me in a temporary different direction because I couldn't commit at a young age to pre-med and all that long road ahead. So I went to my second passion, which was journalism, and got a degree in journalism from Northwestern and went into journalism. But gnawing at me was, I really think I can make a difference. After I spent years learning to be a good communicator, and then I worked with Ted Koppel on Nightline and some other journalism roles, I learned what good communication was all about. And I thought I could somehow make a difference with healthcare providers. I wasn't sure at that point how that would happen, but then I couldn't take it anymore, and I went back to went back and got a medical degree because that's really where my passion and dream was. And did the normal track of medical school and pediatric residency, went into private practice. But again, gnawing at me was, how am I going to make a difference? I saw again firsthand really good communication and not so good communication. I had to do something about it. So I went back and got my master's in public health because a mentor of mine in medical school told me that would be a nice bridge between medicine and communication and the public. So I did. And that brought me to Stony Brook. And I always walk through open doors, and a door opened. Alan Alda at Stony Brook opened this door for me, along with Howard Schneider, who was the dean of the School of Journalism at the time, and offered me a position to help train doctors to communicate with compassion. And that's where I met my partner in crime, Val, and we've been working together for the past 15 years, me bringing my journalism and medicine perspective, and Val bringing her theater arts perspective and so much more. And together, we've been creating novel arts and humanities-based curriculum at the Alda Center for more than a decade. Then we went to start a new medical school and to help start a new medical school in Texas, which was geared towards training empathetic scholars, and our communication curriculum was at the core of that. And then we got recruited to start this center for compassionate communication. And that's what brought us to UC San Diego.
Yeah, talk about a diverse, varied, and multifaceted path you've had. So we're going to dig into that a little bit. Val, can you tell us a little bit about your background as well? I know you come from a slightly different, let's say, starting point.
Yeah, I was a theater artist, actor and a director and a teacher. And as Evonne said, Alan Alda had this idea that he wanted to train scientists in improvisation skills to help them communicate more effectively with the public. And I was one of 3 theater arts faculty members at Stony Brook that was invited to a pilot that he was running. And we were working with graduate students in the sciences to kind of figure out how improvisation might help them connect to their own passion for their work, but also become more adaptable when speaking to public audiences. So we ran this experiment, and then I was invited to sort of launch the improvisation program at the Alda Center, and then met Evonne. And I also had my brother died when I was 15, and so that experience was one of heartache, obviously, but also tremendously good medical communication. And what I felt was that medical professionals had a much more urgent need to be able to speak to the public than many scientists, because they do it all the time, all day, every day. And so Evonne and I really partnered up in trying to figure out how this kind of arts-based training could be helpful and immediately applicable to people who are so busy and need skills in communication.
That's great. It's like I'm talking to 5 different specialists at once. So you got you got actresses and journalists and physicians and patients. And family members. So let's dig into this. What was working in communication and what didn't? Evonne, you mentioned that you had good communication and bad communication. Can you share a little bit about your own personal experience with that, especially with the lens of being a physician and all the other hats that you've worn?
Sure. It's interesting because my perspective as a patient changed, because when I first got sick, I was, 15-year-old young lady, and, I wasn't a physician yet, but my surgeries went over 3 decades, and I was already a physician during my last few surgeries. So I had a different perspective from start to finish. And of course, I became, through that journey, more empathetic for the physician's position as I followed on, because I knew what shoes they were walking in and how challenging their job is, and I was delivered a lot of bad news over 30 years, and I knew it's not so easy to do. So I became very understanding. When I was younger, communications, it was old school medicine. It was in the 1980s, and it wasn't like shared decision making and all of the communication skills that we're getting in medicine now. And I had world renowned physicians, and I loved them. And they also didn't listen or maybe understand where I was at or where my family was at when they were delivering some of this news. And I can tell one brief story of when I was in the hospital for 4 months trying to prevent surgery, the need for an ostomy, a bag, and then I got toxic megacolon, and there was no going back. And we were a very close family, very optimistic family. And I remember being wheeled into this dirty utility room, and I'm sitting in the wheelchair in one corner. My parents are there, and my gastroenterologist, who we really adored, was sitting there. And he basically said, it's time to shop around for a surgeon. And my father, mild-mannered, sweetest guy in the world, but an attorney, he could be tough when he wanted to be, and from the Bronx, so that, that also adds to the layer. He went to punch the doc who he adored, and my mother pulled him off. And, to this day, we're not sure, did he do that because he wasn't ready to hear that news? He wasn't in that chapter of the story yet, or his daughter was going to end up with a bag for the rest of her life. And how would I have redone that visit now? Probably would have asked where we were at, what do we think, this is where we've been, right? Go through the little journey of where we've been and what we've tried, and then ask my father and me and my mom, so what do you think is going on now? Where are we at? And lead us to the point of it's time to get a surgeon. And there was a lot of that going around, a lot of assumptions of, a young girl, I was told by my surgeon, shouldn't have to live the rest of her life with a bag. We're going to give her the state-of-the-art operation. To my family, that meant the greatest, the best. It's been tried and tested. And what I found out in medical school was I was one of the first children to have this surgery, and it landed me 20 other surgeries. So jargon and avoid jargon and listening and trying to understand our perspective. These are signs of great communicators, and that's what we try to teach.
Yeah, I'm curious, was the word shopping for a surgeon actually used? I mean, I've seen myself how just a phrase or a body posture or even just a word that I use can set off either in the right direction or wrong direction a certain dynamic. And I'm curious if that, in the moment, do you remember that being a sort of a trigger point?
Well, I mean, it was right after he said it that my dad, went to punch him, and I did. I was sitting there in my wheelchair. I felt like I was watching my family fall apart, and at that moment I said, I better be the best patient ever because this isn't going very well. And I think the term shopping is obviously not the best term to use, but there was no warning shot. There was an assumption that we were where he was. He's done this story before. How many patients like me has he seen? This was our first rodeo, and we didn't know that it was inevitable, right, to have the surgery. And he knew my dad was a very positive, happy guy and would always, she's going to be okay, right? So when you get to know a family member, you understand what their MO is. It would be, he would have to understand that my dad's, dream of me getting better was going to be squashed, right, in a second. And he needed to give him a warning shot, take him up to the present, and give him some hope.
Right. I mean, and it speaks to something that I've been reading about lately is the principal agent problem. We have And we see this in I guess the psychotherapy world more, at least there's a lot more written about it, where the practitioner and the client have a certain dynamic with, they've described it as transference and countertransference. And for some reason, and I want to get both of your thoughts on this, we don't spend as much time talking about it, thinking about it, reflecting on this when we're in the non-counseling professions, that side of medicine. I don't know. It just seems to be, there seems to be some sort of block there. So before we get into that though, Val, did you have any experiences like what Evonne had in terms of with your family member who was going through that horrible time where you said the communication was good? Were there things that stood out to you as being positive?
Yeah. With my brother's death, I was so young, I was only 15 years old. And so a lot of that memory I'm not sure how dependable that memory is, to be honest, because I was facing an unimaginable circumstance. And what I remember was, I remember both kindness and shock during that time. But I have more recent events that that kind of get to a similar idea that Evonne just shared about taking time and slowing down and thinking about where the patient is. My dad is 94 and he's a stubborn Norwegian, so he doesn't think he's 94. He thinks he's, somewhere in his early 70s. He says, "Oh, you're 70. You're upper middle aged. This is this guy, right?" So he, a couple of years ago, he was falling asleep all the time, and we couldn't figure out what was going on. Why is he so tired? Right? This is not my dad. And so we went to a number of different doctors, and there were, ideas about what was going on. And we went back to his cardiologist, and his regular cardiologist had to take a leave of absence for his own health. And so we went to meet a new cardiologist for the first time, and the room was set up so that the chairs for the patients in the office were behind the doctor's computer screen. So we couldn't even see the doctor behind this computer screen. And he, very quickly, in only a couple of minutes, said, "Well, your dad needs a TAVR, and if he doesn't get this procedure, you can expect that he will be dead within the next year." And we didn't even know why. We thought we were just coming back to get a refill on his prescriptions, and we were completely shocked. And he said, "Well, you can just go watch this YouTube video, and it'll explain everything." And my dad was living at assisted living at that point. He was 92. And, of course, his table mates, it was the whole thing, right? The guy doesn't know what he's talking about, blah, blah, blah. And you need a second opinion, and all of the opinions from the bromance at the table. And so we wasted time. We wasted a lot of time, 2 months getting a second opinion. Then he had he had cellulitis and ended up in the hospital. That wasted us another couple of months. And finally, he did get the TAVR, right? Relatively easy procedure, went very well. He's, 2 years past this procedure, doing very well. And so it was right? Clinically, the information was right. It was the delivery of that information that was so abrasive and wasted us so much time. And we probably wouldn't have listened if it hadn't been for that second opinion. So I don't know, just slowing down, recognizing where people are coming from before you launch into new information.
Right. No, that's a telling story. So what gets in the way? What's the problem? And what I want to get into how the Center for Compassionate Communication can help with that. But where have you identified the real issue areas?
I mean, I'll start, but I think there's a perception that communication takes too much time, and listening takes too much time. And in fact, the research supports the opposite of that. Physicians, interrupt their patients on average 18 seconds. It used to be, now it's, I think, down to 11 seconds. And then then the studies show that if you just let your patient speak, they won't, on average, there's always outliers, won't speak for more than 2 minutes. And in that 2 minutes, they're telling you a lot of stuff, the important stuff to understand who they are and what matters most to them. And a lot of the other questions that you need answered as a physician may come within that 2 minutes. And even more importantly, when somebody feels heard, they feel they can trust the person, that there's, their physician. And once you have broken trust, we all know it's very hard to establish that. So the first 2 minutes of an encounter is so important. And I think that physicians are busy and they're burnt out for good reason, and the system doesn't allow for longer visits. So they're trying to get in all the information, all the things and stuff they have to check off, with the thinking that it's going to take too much time.
Yeah, I also think there's, this phenomenon called the curse of knowledge, right? Where you know something so well, you forget what it was not to know. We have a friend who is an ER doc, and we were texting a while back, and I said, "How was your day?" And he said, "Well, it was just okay. I didn't save any lives today." It's like, wow, okay. I made it through Pilates, but whatever.
Right.
I just think that there's like a different perspective on what health means to caregivers or clinicians than what it means to the public. And just stepping back and recognizing that in almost any situation where you're sick, there's some level of fear there. It doesn't matter whether it's, you have, a bad case of acne, you don't know if you're going to make it to the prom, or if you're, if you need a TAVR, I mean, we're afraid when we're sick, and being able to step back and recognize that it's hard to do because you're so busy. The system is so broken. But that little moment can make a huge difference in the communication that goes back and forth between two people in that room.
I just want to add to that about, the most important foundational skill is listening. And listening, there's different depths of listening, right? I just heard the words they said, or there's deeper listening, which is where you get at, if you really ask the right questions or you listen deeper, you get to that reason that patient is fearful, like Val said. And if you can address that right at the top, right, what their biggest fear is, what their biggest concern is, that patient's more apt to trust you, to open up, and will shorten the visit in the end because you're going to get to a lot of the questions you need answered.
Right. I'll add to this to the discussion as well, is that we do need to listen to the patients, and sometimes I've certainly appreciated how it's not unidirectional. I mean, I think the providers, the physicians, the nurses, everybody, we're feeling the fear too. When someone is sick, we are feeling it. You mentioned Evonne, burnout. Obviously, that is a central theme of this Substack and this podcast. But what I've found is that the interruptions that we do are also somehow to protect ourselves. We also don't want to be in any more uncertainty than we already are. And we also have a problem with compassion fatigue too. And so how do we manage that? So I'd love to hear more about your strategies in the Center for Compassion Communication, which I find are probably bidirectionally useful and fulfilling. So let's get into some of the techniques and the tools, activities in your workshops. I know you have a fellowship. What are some of the key elements of that, and how have you seen providers as well as patients benefit from them?
We use the arts and humanities in a lot of different ways. We use some improvisational skills. We use some narrative medicine. We use some visual thinking strategies. We use a lot of story, actually. And the reason behind that is that it takes the person out of the thing itself and allows them to look at their own personal traps or patterns from the perspective of somebody else's. And the benefit of that is that it lowers defenses and allows us to become creative. And those are really powerful tools because it's vulnerable communication, right? It's based on how we were raised and the cultures that we came from, and our upbringing, and a lot of different patterns and reinforcements. So to be able to break that down or to reimagine it requires us sometimes to be able to step away and look at it from a different lens. And so that's one of the values that the arts and humanities gives us. It also it opens our hearts in a way, and I think that that's really important because when we're communicating well, it isn't about the facts, it's about the connection. And it helps us tap into that in an authentic way.
It also, we think compassion should just be given to others, but we don't practice self-compassion. So when I went through medical school and my training, I didn't even know I had permission to take care of myself, right? It was like, that's on the back burner, and maybe I'll get to that one day, but I need permission to be able to do that, right? And one of our co-director of our fellowship is a palliative care doc, and he was in our first pilot fellowship. And he didn't really realize how burned out he felt until he started the fellowship. And he said the best thing that came out of it for him was the idea and the permission to practice self-compassion. And part of that, the part of the process besides the arts and humanities is it's a group cohort learning experience. And physicians don't get this very often, where they have time away from their practice to be together with others that walk in their same shoes, that feel the same way they feel, but they don't even know it because they don't hear it until they have time to dig deep. And the process, at least in our fellowship, is longitudinal, and they come back, time and time again. And in between, these lessons kind of land and light bulbs go on, and then they come back. And by the end of the fellowship, there is this, definitely a cohort effect and a camaraderie and a love and a respect for each other. But even more importantly, they understand that they need to take care of themselves, and it's okay to practice self-compassion. There was a doc that told me this saying that I use a lot, which is, you can't give what you don't have. And we are always asked to give when we don't have. And so we need to, fill up our cup and practice some self-compassion. And this process that we do, we have data now. Our first paper has just been published in Academic Medicine. We set out to teach communications, but one of our big happy outcomes was that it improved wellness for our fellows.
I love this because you're absolutely right. And this is something that I've written about in the Substack, but I have been doing more and more reading, and I'm reading this one book called The Mindful Self-Compassion Workbook by Kristen Neff and Christopher Germer, and another book called The Resilient Practitioner by Thomas Skovholt and Michelle Trotter-Matheson. These are not new books, and they speak to exactly what you're saying, Evonne, and that I've realized for myself in bits and pieces, but now more than ever, is that we don't have the capacity for self-compassion that's very well developed, because we've spent basically our entire careers pushing it out. It's still somewhat ironic and unsatisfying to remember that getting into medical school, you have to be so diverse. You have to have an arts side of you, and you have to have the scientific side of you, and to merge it just to get into medical school. But then once you're in, all of a sudden, everything is spent to basically push yourself out of the picture, push that diversity out, and become basically a monotone of scientific omniscience almost, right? And training just bludgeons every form of self-care that you can do out of you, so that now our lived experience, our participatory knowledge, as a cognitive scientist would describe it, is now just ignoring yourself and giving everything to outside of yourself. And the Skovholt-Trotter-Mattson book is basically saying something I alluded to earlier, which is the counseling professions and therapy world has done a much better job of saying that self-care is exactly part of the same process as caring for others. If you don't care for yourself, you cannot care for someone else. And they even break it down item by item. You have to care for your nutritious self, your physical self, your spiritual self, your loving self, your priority setting self, your financial self, all these different selves. And it doesn't mean that it's all going to come in one form, nor that is it going to change. It's not going to change over time. We all evolve during our lifetimes, but to put that in the center of our focus and not at the periphery, and not even if I get to it, then okay kind of scenario, that to me is, I think it speaks volumes. And so I'm thrilled that you guys are doing that in your Center for Compassionate Communication, because it sounds like that is exactly what's needed, is to put that back into our minds as not just a want to have, but a need to have, right? And it sounds like in your program, the way you get access to that for the practitioners is to take them out of the system pressures, at least for a brief moment, right? And give them another portal of inquiry and reflection in order to access something that probably has been closed off for a long time. Just like the one of the providers you said didn't even realize that they were burned out. That's just an amazing insight that you can now provide folks. Are there other examples of folks that are in your program or have graduated from your program who've spoken to this kind of, evolution and transformation?
Yeah, we have many examples, but a couple spring to mind. One, we had an emergency room doc, and she was so invested in the fellowship, and she had just had a baby, which is sort of like, wow, how many things are you going to take on all at once? But she was fully in, and what she realized was how much the environment of being in the emergency room was impacting people. Like all these beds in the hall, and people waiting, in chairs for hours and hours. And she said, I changed one simple approach. I just recognized the space. And when I would go to approach a patient in the hall, I would say, I am so sorry that this is what you're going through. This is not the way that I would want my own mother or my own father to be seen by a physician. I'm sorry that you've been waiting so long, that you're in a bed in the hall. And what she found was that this simple entry changed everything. I mean, her patients would come back, well, it's not your fault. And they would start to want to take care of her. And it's, she said it's suddenly a connection was built, like a human connection. And just from a simple change in the way that she approached a patient who had been waiting in an uncomfortable circumstance, changed not only the way that that they were able to hear her, but how she heard them on a much more human level. And her wellness changed. She started getting letters. Evonne, you can tell the story about
She just
this.
recently told us that the chair of emergency medicine, her boss, called her in and said, we're getting all of these really nice comments from patients regarding your communication skills. I mean, how many ER patients leave a emergency room ready to comment about their ER doc? It's rare, and he found it important enough to tell her about it. So,
can you trace that? Can you trace that back to one of the activities or skills that you maybe fostered as part of the courses or the workshops that she did with you guys?
I don't, there's so many different activities that we had done until that point, and she would probably be able to answer that more fully. But I think it's just, there's so much work that we do on recognizing emotion and this is one of the magical things about the fellowship. We know what we know, and we are very clear that we don't know what we don't know. And so each one of our participants take kernels of this content in very different directions. So this just happened to be a filter that she creatively accessed for herself. And this is another thing about the arts, is that it triggers your own creative problem solving. And it was nothing that we said to do. It was just an idea that came to her and that she authentically took on. And so I guess that's the smartest that I can be about that.
Yeah, I love that idea because, and this is the way I just process burnout, is that it's a dynamic process. It's not this, you're not frozen forever, right? And it acknowledges that we come in with certain types of ways we are, right? Ways of being, our psychological tendencies, our personality traits, our value systems, and they change, but they set us up for certain types of experiences. And some of them work well and some of them don't, but it's something that evolves, something that we can have agency over and not just be sort of a victim of, right? And so I love the way that you're describing it, because it's kind of like burnout is almost like a catalyst to unleash our creative power. And when we don't face these kinds of challenges, we are actually doing ourselves a disservice. We have to push ourselves forward. And so burnout, in a way, to me, is not all negative. And it's not just stress, but this is a way to unlock things that probably have been, put in the dungeon for too long. And so I love the fact that your workshops and your program and your fellowship can allow people to find the key to that lock that has been, basically hidden, I don't know, somewhere for so long.
I think that's really important too, is this idea of that it is a personal journey, because we really shy away from the idea that you can script this. Authenticity is not scripted. It happens in the moment, and we all have a bullshit barometer. We know when it's not real,
right.
And then we lose trust when somebody isn't being their authentic self. And it's important to have, we call it back pocket language. Like when words fail, it's important to have, a few analogies or a few ways of explaining some things that are thick and difficult for people to understand. But the reality is that's the last resort. The first resort is connection. And that is not a scripted phenomenon. It's something that happens in the moment. I also have one more story to share of a doctor that we had recently who we were working on giving feedback, and it's a process that was brought to us by an executive coach, Kelsey Brennan, and it has to do a lot with listening. And this doctor, he went through this process, and then he came back the next day and he said, I had the most amazing experience last night. I used this process in a conversation with my son, and it was the best conversation we've ever had. And he said, "Guys, this works." So it's cool seeing how this plays out, not just in a clinical environment, but also in families and in relationships, because you're doctors, but you're whole people. And all of that stuff that you're bringing from home is impacting how you're showing up at work.
It's sort of blurring the lines between life and career. I mean, it's almost like we were trained to only think of them in sort of compartmentalized fashion, right? And the reality is they impact one another. I mean, I felt the same thing myself. When I am better communicator and I feel better, that human connection at work, I'm more available emotionally outside of work, right? And so it's sort of a win-win situation. We've talked a lot about the individual finding an individual path, right? And obviously there's always the agent arena phenomenon, right? There's always a dynamic there. So do you have any thoughts about how institutions can support better communication? What could the system do or the institution do to help you in your own efforts?
Well, I would start by leadership modeling, listening, and communication, but with their faculty and staff. When we came to UCSD, there was not an alignment between the faculty and the leadership, and communication's always at the root of that. And I'm sure the leadership and the staff and faculty both have the same goal, right? They want to have good care for their patients. So it's not that they're looking at this differently. It's just that they're not communicating and connecting about it. So that would be important. The reason we came to UCSD was because we saw from other institutions that you can't just take a 2-hour communications course and call it a day. We had great results in smaller snippets, but it needed to be longitudinal. It needed to give time to our learners so they could process it. So we came to UCSD with a lot of lessons and a lot of things that we thought would make the experience better and stickier for our learners. So we started this fellowship and by buying out the time of our learners so they could put their work aside and actually be in the room and be present. In fact, one of the biggest results on our data from our research is that they were so grateful that the institution was supporting them to do something like this. Like that was like numero uno for them, is that their institution cared enough to bring us here to do this kind of training and to give them the time to do it. So I think it's very hard to make anything mandatory at an institution. So we are from the school of thought, start with low-hanging fruit. If you build it, they will come. And then people want to do this on their own. And that's exactly what's happened here. We started with those low-hanging fruit, the people that, really were passionate about it. And now people just are coming because of word of mouth and because they want to do this. And then there's always the people that don't realize they need more training than they have and are unreachable and don't get it. And there have to be some mechanisms in place to help foster that for themselves too. Because oftentimes it's not really the communications that's the problem. There's something deeper. There's burnout. There's issues, with family. To spend the time to really get to the thing beneath, we call it the thing beneath the thing. What's the real reason for this particular provider having communication issues?
Right. It does seem important that the institution has obviously supported the existence of the Sanford Institute and your efforts. So that itself is definitely a step in the right direction. Okay, as we sort of close here, I wanted to ask both of you for just a practical, 1 or 2 tips for people to take away from this, even though, yes, we need them to all take your course and your workshops, but if they can't, or let's just say a little teaser, what would you tell the listeners here as far as whether they're a medical student, resident, attending physician, in order to enhance communication and unlock some of what lies beneath?
Yeah, I mean, we've spoken about this already in this meeting, but I think just slowing down is so important. There's time, and then there's the perception of time, and doctors are so busy. I mean, it's insane what you're expected to do in a short amount of time, but I think the reality of that has created a perception of time needing to move faster. And the reality is that if you slow down, at least at the beginning, a couple of minutes, you'll gain trust and you'll get there faster in the long run. It would take a concerted effort and a leap of faith to give it a shot. But that is one takeaway that I hope that we can impress on people is just focus on that first 2 minutes, slowing down and listening, and see how that changes not only what's happening for your patients, but what's happening for you as a provider, in your connection and in your joy, even in your work.
Just add to that. What I do for myself is I literally will try to feel something in the moment, like how long is the time going by, and then I actually check myself in my watch. Actually, not my watch, my phone. Just to see how much time was actually going on. The other thing is I use sort of some breathing techniques before I go into a family meeting, so that my body is now feeling a sensation of, okay, the breath is coming in. So that when I'm in the moment, I'm actually noticing my breath a little bit more. So those are two things that I use.
Wow,
I don't know if you have
that.
others to add to that, or Evonne, if you want to continue.
Yeah, no, I like that a lot. I mean, everybody has their own tools or magic, and we learn from everyone else as much as we teach them. So I appreciate you sharing that. I think it's important to be aware that communication is a journey and not a destination, and you will very rarely nail it. It's a practice, just like medicine, and it's never the same. And you may be delivering the same news, but it's never the same because there's always somebody different on that receiving end. And that takes being comfortable with uncertainty, right? Surfing uncertainty, which is the antithesis of what we learned in medical school, right? We want answers, we want to give answers, but if you can get comfortable with surfing uncertainty, you could be more present in the moment. You won't be scripted. And the most important thing is you'll be authentic. And that's like to me, if you ask me one important word, it's authenticity. It's most important for the patient because, like Val said, they'll see right through you. But, moral distress is a real thing with physicians. And I think if they can just be their authentic selves in terms of communicating, that could help, towards that as well, to be who you are in the moment. There are rules, of course, of engagement, in communication, but be authentic. And that will help establish trust with your patients and your colleagues. Team communication is key also.
Yeah, the authenticity it's both sides, right? So it's the yin and the yang. So we do things well, but we do things not so well, and to embrace that Jungian shadow self, the things that we don't want people to see or to know about ourselves, we embrace that and see that mistakes are not. It's not a one and done. It's not like, you're not going to go to hell just because you made a mistake. And like you said, Evonne, it's a journey. So the next time, there's always a next time to try to do a little bit better. But having forgiveness and patience with yourself as you do that, I think that certainly helped me in my own path. Okay, well, I really appreciate both of your time for this morning. And we will see you soon.
Nice to meet you.
Yeah, thank you.
For those who want to find out more or become more involved, the Center for Compassionate Communication, as part of the Sanford Institute for Empathy and Compassion at UC San Diego, will continue their fellowship twice a year, and at the end of this year, they'll have over 100 graduates. They also have a shorter version of this curriculum delivered in a 2-day conference called Lead with Compassion that is open to both UCSD and external doctors and nurses. There are also plenty of free trainings, including a monthly Zoom series that begins in September 2025, as well as 2 courses on Coursera. For medical educators, they offer their facilitation guides for their online courses and a full facilitation manual of most of their curriculum, including videos to show the content in action. As part of the written post of this podcast, you will see a QR code that you can click on to take you to a landing page where you can learn more about each of these opportunities. I hope you enjoyed this post. In upcoming episodes, we'll talk more about erroneous myths in medicine and have an interview with a family medicine physician who faced burnout firsthand and made some interesting choices on her own journey forward. See you then.